So imaging is actually central to the diagnosis of invasive fungal infections. And in the first of its guidelines that they issued, the EORTC MSG group actually put imaging features as a major criterion. And as you know, the symptomatic features like chest pain and hemoptysis, those only were a minor criterion. But it's also important to see this thing that at that time, they allowed for any new infiltrate not fulfilling major criterion as a minor criterion. So you could include patients in your studies if they had some sort of abnormal chest x-ray as well as cough. And as you can see, that was quite loose. So in the 2008 update, the group actually made the criteria more stringent. And as you can see, for the diagnosis of pulmonary IFIs, only the radiological criteria remain. And it's actually limited to basically it's just two things, either a nodule with a halo, with or without a halo, and then Air-crescent and cavity are basically the same thing, as I will go through afterwards, although they have slightly different names. So as clinicians, we see X-rays and CT scans every day, and as well-trained individuals, we are all very, very smart. When we see something like this, we will say, oh, this is a Klebsiella pneumonia, isn't it? This is a bulging fissure sign. And when we see something like this, we will say, yeah, this is pulmonary tuberculosis. So we are very smart, and we can almost make a microbiologic diagnosis from just an image. But is that really true or not? Obviously, this is not a microscope, and we are not seeing a bug, right? We are seeing the consequence of a process that is blocking X-rays, and that process could be blood in the alveoli. It could be an inflammatory process with cellular debris and edema in the interstitium, blocking the airways in varying degrees, producing an image that we capture on film. So the truth, of course, is that when we see an X-ray, although we expect our students to say that bulging fissure sign is equal to Klebsiella pneumonia, the truth is that the X-ray does not give you a microbiologic diagnosis. So people, of course, have long understood that, and they have tried to understand from the earliest days of chemotherapy the pathologic processes behind aspergillosis. So in those early days, of course, lots and lots of their patients died, but it was also in those days that they did many autopsies. So this is a study, I think, more than half a century old by now, but a very good study, only autopsy-proven cases. Everybody had to have a chest X-ray no earlier than 4 days before death. And basically, they found that the radiologic pattern, just like the pathology, basically consisted of two types of lesions, either a nodule or a hemorrhagic infarct. And they said that the nodular lesion had a characteristic appearance, meaning they were ground, they had a grayish-yellow center, and they were all surrounded by a rim of hemorrhage. And they called those the target lesion or the bullseye lesion, which translated radiographically into a nodule. And this is what it was like, grossly speaking. There's an area, the center is all fungus, because these were almost all neutropenic patients. There's an area of necrosis and hemorrhage. And basically, if you catch a small arteriole, you can see fungal hyphae within. So this is a more recent picture showing the same thing, the nodule in the center, almost all fungi, an area of necrosis, and then an area of hemorrhagic lung. So basically what has happened is that there has been an infarct, right? So of course in the bigger setting you can see almost a triangular shaped lesion corresponding to the territory of a blood vessel. So basically the problem is a hemorrhagic infarct. There is a large wedge-shaped pleural-based lesion, which in all cases is caused by thrombosis of a pulmonary artery because the fungus had invaded. And this is the theory that they put forth, and this has been shown to be true by various types of experiments since then, that we are all inhaling Aspergillus every day, right? Aspergillus is ubiquitous in our environment. So there is some fungal proliferation in the airways in these compromised patients, and then there'll be transbronchial invasion, and at some point it will enter a small pulmonary artery, small enough to block off the entire blood supply so that there is ischemic necrosis, right? And as the fungus keeps growing, it will branch out into neighboring arteries, and that's why these lesions can coalesce on your X-ray or CT scan. So basically, whether a nodule or hemorrhagic infarct, the pathogenesis is actually the same. But of course, today we are no longer reliant only on X-rays. We have this wonderful thing called the CT scan, and therefore this thing called the halo sign. So the halo sign is basically a nodule with a surrounding ground glass rim, a rim of ground glass attenuation. And sometimes you must play with your CT scan. Everybody has got X-rays on CD-ROMs and computers nowadays. You can move this up and down, and if you go one cut down, you can also see the ground glass attenuation. So the encirclement is actually in 3D. And over time, and this is an important thing, over time you will see the cavitation, meaning that something else is happening. And this usually occurs when the white cell returns. So what this means is that the entire process is actually a changing process. It is dynamic. And therefore, the halo sign is also dynamic, meaning it is transient. You are not going to see it in every patient that you scan. And this was recognized a long time ago. And when these French investigators tried to study all these in detail, the CT features of these nodules, what they call an aspergillary nodule, and they measured the volume, right, which is not difficult, just length times breadth times height. So they called day 0 the first day that the CT had a halo sign. And as you can see, as the days go by, no matter whether or not the patient is treated, the volume of the lesion will increase, and it will take time before it will come down again. Of course, you may criticize the study by saying that in those days they only had ampho-B and itraconazole. And an Air-crescent would only appear after the polymorphs return. So this is a larger study. This is a very good study. There were 40 patients yielding more than 300 scans, and as you can see various types of CT features, nodules of varying sizes from very small to large, and then areas of consolidation. And it's interesting that about a quarter of the patients just had one nodule, but you also have patients with anything from 5 to 20 nodules. So sometimes we think that when the patients have many nodules, it's not quite likely to be Aspergillus, but it is possible. So this is just one feature. So as you can see early on, you will see these. As you can see, the nodules are of varying sizes, because obviously by the time you scan, it's not the first day that the fungus caused an infarct. And that's the halo around it, right? That's the ground glass attenuation. And the halo is an area of hemorrhage because the lung has got dual blood supply, right? So although you block off the pulmonary artery, there is a bronchial artery. And in time to come, irrespective of therapy, some of these will coalesce. And as you can see, there's a hint of halo still, but it will take about almost up to a month, 2 weeks after this, before you will see some shrinkage. And it will be 3 months before it will be reduced to a scar. So because they had more than 300 scans, they could represent this graphically. On the first day, then it will take a week before it reaches maximum size, and it will stay at maximum size for about a week before it starts to reduce in size again. And it will take close to 90 days before there is CT resolution. So if you're treating your patient, an increase in size doesn't mean treatment is failing. Now what then of this halo sign? So halo sign, like I said, is a transient sign. If you scan early, you are likely to see it. The earlier you scan, the more likely you are to see it, right? And if you take 1 week after symptom onset, then only about a third of the patients will have the halo sign. Of course, that's very difficult because what is symptom onset? Is it first day of fever? Is it first day of cough? But these are non-specific symptoms. Similarly, the crescent sign is a late sign. As I've said, it comes about when the white cells return. So if you scan very early, you are not likely to see the crescent sign. It is something that evolves over time. So what is this halo? Like I said, a halo is a ground glass attenuation surrounding the nodule. It is the representation of a hemorrhagic infarct in an organ that has got 2 blood supplies. And as you can see, it need not be caused by thrombosis, right? It can be caused by vasculitis. And if you think about it as an area of hemorrhage around something, then maybe it could be caused by fragility of neovascular tissue, by some sort of necrosis, by a bronchoarterial fistula. So these authors had a few cases of the halo sign in the hospital that were not caused by invasive pulmonary aspergillosis. So they decided to scour the literature, and they found a whole long list of reports where people had described conditions showing the halo sign, right? From Kaposi sarcoma to MAC pneumonia, pulmonary endometriosis, osteosarcoma, and even vagus. So here are some examples of patients having diagnoses other than IPA with the halo sign. So this is a patient with vagus. So as you might imagine, as you know, vagus is a vasculitis. So medium and small size arteries can undergo some sort of vasculitis, which is blockage of the blood supply. Similarly, you can get it in KS. These halos, the nodules and halos are very small here. But as you can see, there's a vascular tumor, the wall is fragile, you can imagine that some bleeding will occur. But of course, we are dealing with a different type of patient. We are dealing with patients with AML, who have had chemotherapy and who have been neutropenic for 16 days. So context is everything, of course. It's how you interpret a piece of a publication like that, just to tell you that this is not a specific or diagnostic sign. Now, the other category of patients who are quite likely or who are always listed as being at risk of aspergillosis would be the solid organ transplant recipient. And as we know that these people are rarely neutropenic. So would the CT features be similar? So the answer is no, at least from this Korean paper. They looked at a large number of patients who had all their patients with invasive pulmonary aspergillosis, and classified them into whether they were organ transplant recipients or neutropenic hosts. And as you can see, the organ transplant recipients were less likely to have fever, more likely to have ground glass changes, and a halo sign was actually quite unusual. Of course, this again is a single center study. Other people have had slightly different experiences. But the reason why you would think that it is likely that the solid organ transplant recipient and the neutropenic patient will have different signs is because the pathology is different. And this is a sort of experiment repeated many times over where they induce lesions, where they induce invasive aspergillosis in rats by injecting aspergilli into the rat, right? So you can render them compromised in various ways. You can give them cyclophosphamide, or you can give them high-dose methylpred. And you will see that the pathology is very, very different. So in the steroid-treated mice, you may not see loads and loads of fungi, but you see all these pneumonia. Whereas in the chemo-treated mice, there are very few white cells, lots of fungi. They may not suffer as much by way of respiratory distress, but you will find that they disseminate very easily, and you will be able to culture aspergillus from other organs as well. Now, a more recent experience, and this is the Chinese, this is a center in Guangzhou, and they actually were able to show that their IPA patients had a frequency of signs that sort of resembled the chemotherapy individuals. I thought this was a bit odd that you have more halo than nodule, but anyway, a good number of, quite a lot of halos here. I think it may be that over the years, with a lot of awareness, a lot of teaching, a lot of attendance at MMTN maybe, the author's awareness of IPA and of the transient nature of the halo sign may have led to a very aggressive screening strategy. So I'm not really clear as to all the hows and whys, but basically when we're dealing with a different category of patients, we may not expect the same set of signs. So how good is the halo sign? How useful is it to us as clinicians? So this is, again, an old paper, and again, the proof of aspergillosis is absolute because all of these patients had to have autopsies. And you find that, sure, there were a variety of bugs causing pneumonia and a variety of other conditions. So I show this slide to show you that when you are dealing with these very sick people, an X-ray, a radiological infiltrate need not be a fungus and need not even be infective. But if you look at the CT findings, the halo would be highly associated with invasive pulmonary aspergillosis. And all the rest, like the wedge-shaped consolidations and all that, maybe were less strongly associated. So from a clinical sense, and if you go for a set of patients with proven IPA, then the halo would certainly be important diagnostically. And so with that, people realized that they could use CT as an early diagnostic indicator. So this is a paper from before the days of galactomannan, where if you use CT, if you scan systematically, very quickly with CT, that's what they did. You find that if you scan at the drop of a hat, meaning whether fever or cough or chest pain, then you find that you would shorten the number of days to clinching a diagnosis. If you see the halo, you can say that this person likely has IPA. And then you also find that you can reduce the death rate from 50 to 17%, which is quite dramatically shown in this graph. So because of that, as you can see, many people decided to change their strategies, and this is the basis for a change from an empirical antifungal strategy in febrile neutropenics to one that is diagnosis-driven, or what some people call a preemptive type of approach. So this is one of the earliest papers. It's a Sentinel paper published by Johann Martens, in which they combine galactomannan and CT in a series of febrile neutropenics, and they were able to show no difference in mortality compared with empirical treatment, but also much reduced use of antifungals. And other groups have done the same thing. This is a British group, and they used only CT, no galactomannan, and they were able to show that you actually reduce the use of antifungals, and you do not get a death from a fungal disease. But those who were positive, you could use caspofungin, and probably only one case of IA would slip by. So this sort of approach became more popular, as you know, in the febrile neutropenia literature. Many people are veering away from empiricism, and this is sort of tailored approach or diagnosis-driven approach, which is very popular. When the fever doesn't go away, then it is time basically to scan and to look for things like halo and cavity. So the halo is important, but as I have said, it is a transient sign, and these are investigators in the US, and they looked at all their cases of proven and probable IPA. And when they looked backwards at all the early CTs, they found that a good number actually could not fulfill the 2008 EORTC criteria. In fact, a third, or slightly under a third, would not meet the EORTC criteria. But if you scan again, then they would begin to meet the EORTC criteria. So basically, what I think happened was that these people, you were not able to show a halo, right? Because the EORTC criteria were very, very strict. Sorry, I thought I had put on the criteria again. Basically, the major criterion for diagnosis means you have to have halo, cavity, or crescent. So these people probably did not meet. But if you scan again, I suspect that was when the white cells came back and the cavity appeared. So they were able then to include the patient in this study. But when you look at 1 to 3 months survival, then they were basically the same. So these investigators said that they thought the EORTC criteria were too restrictive, and in their paper they suggested a revision, right? But let us try to understand what was in the minds of the authors of the EORTC criteria. Basically, these were designed for inclusion of patients in clinical trials, right? They wanted a homogeneous population of patients for research purposes. They should not really guide treatment decisions. These should not be taken as strict rules for making or excluding the diagnosis of an IFI in clinical settings. So it is only by understanding that these signs evolve, that you may miss a halo, that the diagnosis may be clinched a bit later when the cavity appears, but it doesn't mean you must wait till the cavity appears, that you will understand that when you have an at-risk patient, it may be necessary to start ampho-B or nowadays voriconazole much earlier. Okay, since this is a talk about imaging and not just about halos, I thought I should go through some of the other signs that you could look for. And as you can see, apart from the nodule with or without halo, there's also mention of Air-crescent and cavity. So again, going back to medical school days and the days when we trained for the MRCP, actually Air-crescent sign was diagnostic of an aspergilloma, isn't it? An aspergilloma is a saprophytic infection in a pre-existing cavity, and usually not very, very different from invasive pulmonary aspergillosis, although hemoptysis can be life-threatening. Right? The hyphae will peel off, and then together with debris or blood or whatever, it will form an intracavitary ball. So the halo is this translucent thing, the blacker part, which looks like a crescent moon. What is important is that the ball will move, right? Because it has broken off from the wall. So if you prone the patient, this is the patient terbalik, right? That's the vertebral body. Where is the vertebra? That's the vertebra, and this is the mediastinum. You find that the cavity is always on top, right? Because air always floats. So this, generally speaking, the shifting in position of the ball is was highly characteristic of an aspergilloma. Whereas the Air-crescent that the EORTC is referring to is an Air-crescent sign in IPA. So we should be very clear about this, and as usual, context is again everything. So here basically there's no pre-existing cavity to talk about. You are not talking about this saprophytic colonization, right? And the cavity is due to parenchymal cavitation. This process of invasion, necrosis, when the polymorphs come in and they produce a lot of enzymes that attempt to destroy the fungus but also destroy normal tissue. Some of it will break down bronchial walls, and some of those bronchi will allow air into this mess that's in there, and that's why this cavity will occur. And that's why it typically occurs with WBC recovery, because you need all these white cells and enzymes to destroy these walls and open a communication with some airway. Now, this is another interesting sign. It is not well emphasized. Anyway, it is not in the major criteria of the EORTC, but it's called a hypodense sign. But you have to go to your radiologist and sit down with him at the console to see this sign. You have to change it to what they call a narrower soft tissue window on an unenhanced scan to see this. And people again have studied this in some detail. First appearance is about from day 23 to 23, and it precedes the Air-crescent. The specificity is actually very, very high, although the sensitivity is not very good. And it's something that's very easy to miss if you don't window it properly, or if you use a lung window, of course you will not see it. So if you don't see a crescent, it may be worthwhile to go downstairs or upstairs a good chest radiologist, sit down, force him to sit down with you on the console and change some of the windowing. Now, this is the other thing. As I have mentioned, the pathophysiology is basically a thrombus in a pulmonary artery, right? So that's actually pulmonary embolism. So why not do a CTPA? And will a CTPA actually help? So the answer is yes. You can see what they call a pulmonary artery cut-off sign. So here, the pulmonary artery, this branch is going onwards, but this branch has stopped here, and this was indeed a proven case. And I think this is also a nice case. This pulmonary artery comes here and it stops short where there is this lesion. So clearly, this is where the radiology supports the theory, our understanding of IPA. As we know, the pathogenesis is actually a pulmonary infarct. But you can see a false positive, MSSA, Staph aureus, as you know, is hematogenously disseminated. So, of course, conceivably, it can produce the same sign. But this is a true negative in a bacterial pneumonia where the vessel causes right through it. You can do this if you are desperate. Nowadays, we are less desperate because of things like galactomannan. But these are just good things to know. The other thing is that we often do a CT scan in our patients without CT contrast because you know that these patients are already suffering from aminoglycosides and cyclosporin and tacrolimus. Okay, this is another interesting picture. My registrar WhatsApped me this very picture when I was attending MMTN in Bangkok last year. And this is a scan I had ordered just before I left. So this is quite the opposite of a halo. It is the central portion that is ground glass. So this is the reverse halo, and it is highly correlated with pulmonary mucormycosis, right? So this was one of this is one of those papers where they look at 16 patients with proven pulmonary mucor, and of those 16, if you do an early CT scan, you find that 15 of them had a main lesion with this reverse halo. And this is from an earlier paper. I think this is from MD Anderson. They looked at 189 IFIs, and 37 of them had pulmonary mucor. And of these, only 8 had this reverse halo, but 7 of these 8 actually had zygo. And this sign was seen in 19% of the pulmonary zygo patients. So in this paper, you can read some of the details. It's usually solitary, it's usually in the upper lobe, median is 5 cm or something. But basically, again, another very useful tool, because here then you wouldn't start voriconazole, right? It is pulmonary mucor is not going to respond to voriconazole. You would start M4B, Ambizome. So and these are some of the data that you can find in the paper. So, these signs are very useful. Quite apart from diagnosis, I'm just going to take a little bit of time to look beyond diagnosis. I think Yi-Chun already spoke on this, that the halo sign does have great specificity and positive predictive value for invasive aspergillosis. And the other thing is that it is a sign that has a good prognostic, is a good prognostic indicator, because survival is actually better in patients with the halo sign. Most likely because the scan was done earlier and you were able to start treatment earlier. But anyway, this sort of data is there. This slide was also shown by Yi-Chun. This is by Reginald Green from the Global Aspergillosis Study. No matter whether the patient was randomized to the M4 arm or the voriconazole arm, those who had the halo sign survived better. And similarly, if you look at cavity, cavitation is also a good sign. Like I said, it is a sign that the white cells have improved. And this is another, I think this is the German paper that I quoted earlier. And they were also showed that the survival was better when the cavity was seen. And in fact, this is another way. This is a graphical, one is a table and one is a chart form of representing the same data. So in summary, the latest EORTC guide, which is already 9 years old by now, only uses, oh goodness, where is it? only uses radiological criteria for the clinical component of the pulmonary IPA diagnosis or any IFI, pulmonary IFI. The halo sign is caused by angio invasion and tissue infarction with surrounding hemorrhage because the lung has a double blood supply. The halo sign is a transient sign, but it is associated with improved prognosis. The Air-crescent sign, you must use the term correctly. The crucial thing, of course, is pre-existing, whether or not a pre-existing cavity was present. And CT, as you know, is an important pillar of our diagnostic efforts. I think nowadays we don't doubt that. We all do CT scans at the drop of a hat. And if you see a reverse halo sign, then the drug to start is ambisome rather than voriconazole. Thank you.